Hello, and welcome to another great AFM tutorial. In this tutorial series on clinical guidance during the COVID-19 pandemic, AFM aims to provide clinical resources on the management of COVID-19 disease with a focus on low-resource settings. However, please keep in mind that clinical guidance does not replace bedside decision-making, and all guidance here should be adapted to your local setting and to the patient in front of you. Today, we will cover the topic of oxygen therapy in the suspected COVID-19 patient. In this tutorial, we will focus on the progression and escalation of oxygen delivery in these potentially unwell patients. We will look at when to start oxygen therapy, the different forms of oxygen delivery, and how to choose and progress from one form to the next. Hopefully, by the end of this lecture, you will feel more confident in basic oxygen therapy management of these patients. We will be discussing the first line or basic forms of oxygen delivery, working up from nasal cannula to the combined nasal cannula and mask with a reservoir bag. A point to highlight early on here is that all these forms of oxygen therapy should be delivered with the additional use of a surgical mask to reduce potential spread of infective aerosols. Don't worry, we will explain this in full as we work through the lecture. It is important to note that the more advanced forms of oxygen delivery, such as high-flow nasal cannula, non-invasive ventilation, and mechanical ventilation, will not be covered in this tutorial. But stay tuned. We will be covering these in future AFM tutorials. So to start, let's talk about which patients need oxygen therapy and how we identify them. In general, the WHO defines patients requiring oxygen therapy as those with evidence of emergency signs, such as obstructed or absent breathing, severe respiratory distress, cyanosis, which is a blue discoloration around the mouth and fingertips, signs of shock, coma, or convulsions, as well as any patient with an oxygen saturation of below 90% on room air, as measured via pulse oximetry. However, in this tutorial, we will be focusing on adult patients with COVID-19 disease, for which the WHO recommends oxygen therapy in the severe and critical WHO disease severity categories. So this brings up the WHO COVID-19 severity classification. On the slide, you can see a simplified version of the 4 different WHO severity categories for COVID-19 disease. I will give you a few moments to have a look at the table. The patients with COVID-19 disease that are categorized as mild, in other words, those patients who meet the case definition but do not have clinical features of pneumonia, or, in the case of moderate disease, may have clinical features of pneumonia but have an oxygen saturation of 90% and above on room air, do not require oxygen therapy. However, the patients with severe and critical COVID-19 disease do require oxygen therapy. Patients with severe COVID-19 disease have the clinical features of pneumonia plus a respiratory rate of over 30 breaths per minute, or with room air oxygen saturations of less than 90%, or they have a severe respiratory distress. If a chest X-ray is available, it may show bilateral ground glass opacities, which look like fuzzy white patches on both the lungs. The clinical features of pneumonia are cough, shortness of breath, as reported by the patient, and fast breathing. Critical disease in COVID-19 is characterized by either sepsis and septic shock, or ARDS. Sepsis occurs when the body's organs stop working properly, what we call organ dysfunction, in the presence of confirmed or suspected infection. Signs of organ dysfunction from sepsis and shock are altered mental status, which can make the patient confused or difficult to wake up and unresponsive, difficulty breathing with a fast respiratory rate and a low urine output, a fast heart rate, a pulse that feels weak, cold hands and feet, a low blood pressure, and skin mottling. ARDS, or acute respiratory distress syndrome, can also occur in critical disease, in which patients' oxygen saturations are very low, even with oxygen therapy. We won't go into too much detail of the clinical features here, as the focus of this tutorial is on basic oxygen therapy, but more information can be found in the AFM clinical guideline, available on the link displayed. All of that may sound pretty complicated, but the most important thing to remember is, if you think a patient is displaying a problem with their breathing or has an oxygen saturation recording below 90% on room air, then you should consider starting oxygen therapy. Before we get started on oxygen therapy devices, there are just a few things to remember. The first thing to remember is that the air all around us is made up of a mix of different gases. It has about 21% oxygen in blue and about 78% nitrogen in green, with the remaining 1% made up of small amounts of CO2 and other gases in yellow. Sometimes, for patients that are sick, especially with infections that affect the lungs like COVID-19, this 21% of oxygen isn't enough, and they require higher concentrations of oxygen to feel better. That's where oxygen delivery devices come in. Oxygen delivery devices increase the percentage concentration of oxygen breathed in or inspired by the patient. As you can see in the graph, the concentration of oxygen can be increased from 21% all the way up to almost 100% with an oxygen delivery device. The percentage of oxygen delivered to the patient is sometimes called the FiO2, or fraction of inspired oxygen. And this is influenced by how many liters of oxygen is flowing through the device. The flow rate is measured in liters of oxygen per minute and is set at the oxygen source, which can be from a wall oxygen point or from an oxygen cylinder. If you increase the flow rate, you increase the FiO2 or oxygen concentration that the patient is receiving as well. Since you can increase the FiO2 or oxygen concentration that a patient is getting by increasing the flow rate at the oxygen source, you may think that you can simply increase flow rates all the way up for any device. But different oxygen devices have different maximum flow rates and give different maximum FiO2s or oxygen concentrations. We will go through each of these in detail. Okay, let's briefly recap what we have learned. We have so far identified which patients need oxygen therapy, those with severe and critical COVID-19 disease, what oxygen therapy is, and that different oxygen delivery devices give different oxygen concentrations. Great job on discovering all this new information with me. Now we will have a look at how to start and progress oxygen therapy on an actual patient with COVID-19 disease. This slide shows an algorithm or a step-by-step process for oxygen delivery. We will look at each step in detail shortly, but as you can see, we start at the top with nasal cannula and move on to the simple face mask, then to a mask with a reservoir bag, and finally to the combined nasal cannula and mask with a reservoir bag. At each step, if the oxygen saturations of the patient remain below 90%, or if the signs of respiratory distress do not improve, then move on to the next step. We will start by looking at nasal cannula oxygen delivery. This is the first step in the algorithm, nasal cannula oxygen delivery. Let's look at how to perform this. The first line device in oxygen delivery is the nasal cannula, sometimes also called nasal prongs. It is the starting point for oxygen delivery therapy. It is the most comfortable device for patients who need oxygen to use and therefore is the most tolerated by patients. This device can deliver an oxygen flow rate of up to 5 liters per minute and give a maximum FiO2 or oxygen concentration of about 40% to the patient. If the oxygen flow rate is turned up higher than 5 liters per minute, it causes drying of the nose mucous membranes and is very uncomfortable for the patient. So don't increase the flow rate above 5 liters per minute. In suspected COVID-19 patients requiring oxygen therapy, start at the highest flow rate, which is 5 liters per minute, straight away. This will provide 40% of oxygen to the patient as an initial step in the COVID-19 oxygen delivery algorithm. Let's look at how we actually apply the nasal cannula device. First, you must choose the correct size of nasal cannula set to use. If you have different sized nasal cannula at your facility, then select the appropriate size to fit the patient's nostrils. Once you have selected the nasal cannula, attach the opposite end of the tube from the nasal prongs to your oxygen supply. This may either be a piped wall supply or an oxygen cylinder. Then turn the oxygen on to the desired flow rate, which, as we mentioned before, is 5 liters per minute in COVID-suspected patients. The next step is to insert the prongs into the patient's nostrils. If the nasal prongs are curved, aim downwards within the nostrils. If the nostrils of the patient start to turn white or pale after you have inserted the nasal cannula, then the nasal cannula you are using is too big. Remove these immediately and use a smaller set. To secure the nasal cannula in place, wrap the tubing behind the patient's ears and move the slider up the tubes towards the patient's chin, adjusting the fit. After applying the nasal cannula, the patient should be monitored for a suitable period to ensure an improvement. A surgical mask can then be placed over the patient's nose and mouth to reduce the spread of aerosols. If the patient improves, the respiratory rate and shortness of breath decrease, and the oxygen saturation rises above 90%, then you can consider reducing the oxygen flow rate to 3 or 4 liters per minute. However, if the patient's condition does not improve or the oxygen saturation remains less than 90%, you must then move to the next step of the algorithm. A common error is to apply the nasal cannula around the patient's head and neck as shown. This is the wrong way to do it. It can easily result in accidentally choking the patient and is therefore not recommended. Let's talk for a minute about monitoring for improvement. How can you know whether your oxygen therapy is working? Monitoring for improvement or deterioration is an essential step and must occur after every oxygen delivery intervention, whether placing a new device or changing the oxygen concentration on the current device. Please bear in mind that we are talking about oxygen delivery devices in general here, not specifically the nasal cannula. The following guidance therefore applies to all devices. You can check on whether your patient is improving or not by monitoring the patient's oxygen saturations and respiratory rate, not forgetting to ask the patient how their shortness of breath is as well, as this is very helpful in guiding oxygen therapy for COVID-19 patients. It is important to take these observations of oxygen sats and respiratory rate 5 to 10 minutes after the oxygen is started or adjusted, as it takes time for the SATS probe and the body to adjust to the new oxygen level. In other words, you will only see the effect of your oxygen therapy 10 minutes after you start or alter it. If the SATs rise above 90% and the respiratory rate drops below 30 breaths per minute, this shows improvement. This is what we want, and these are the goals of our oxygen therapy. In this case, you can leave the patient on the flow rate that you have set whilst monitoring the patient at frequent intervals. But if, after 5 to 10 minutes, there is no improvement in oxygen sats and respiratory rate, then you will need to act in one of two ways. In the first instance, by increasing the oxygen flow rate at the source, going up 1 to 2 liters per minute at a time. So, for example, if you have set a flow rate of 8 liters per minute on a simple face mask, then go up to 10 liters per minute. Wait another 5 to 10 minutes, then check for a response in the SAT and respiratory rate. However, like in the case of nasal cannula, if the device you are using is already at maximum flow rate, then move to the next step in the algorithm, which may include moving on to the next device or even referral of the patient to a higher level of care, according to local protocol. You should use this approach whenever you are escalating oxygen therapy in any oxygen delivery device that you use. Let's summarize all this on the next slide. Now, I know most of you will be very familiar with how to take a respiratory rate and measure an oxygen saturation, but it's good to go over the basics again for everybody, so bear with me for just a minute. To count the respiratory rate, it is important to count the chest rise precisely and not just guess. Expose the chest if you need to see more clearly by undressing the patient partially or lifting his or her clothes up. Count the chest movements for a full 30 seconds and then multiply this number of chest movements by 2. Do not count for just 15 seconds and multiply by 4, as this can lead to inaccurate respiratory rates. If you count 10 breaths in 30 seconds, multiply this by 2 to get 20 breaths per minute, which is often abbreviated to 20 BPM. To measure the oxygen saturations, make sure the device is on. Make sure that the fingernail used is not painted with nail polish or otherwise obscured, as this could alter the reading. Remove nail polish if necessary with acetone. Place the probe on the finger and wait 5 to 10 seconds for the reading to settle. Some O2 saturation machines have a graph that lets you look at the pulse waveform. If you have a strong waveform, you can be even more certain that this is the correct reading for the patient. Document the O2 saturations in the notes, along with the respiratory rate. Make sure that you disinfect the probe after each patient use to prevent the spread of disease, including the spread of COVID-19. Don't forget to also ask the patient how they are feeling, specifically if the oxygen therapy is helping their shortness of breath. This has been found to be very useful to indicate improvement in COVID-19 patients. Okay, great job. Let's summarize the key points of monitoring for improvement and what to do if there's no improvement. Firstly, remember to wait 5 to 10 minutes after starting or adjusting oxygen therapy. Check the respiratory rate, the oxygen saturations, and ask about shortness of breath. If there's improvement, great stuff. Continue to monitor the patient at regular intervals. If there's no improvement, do something. You can do something by increasing the flow rate, or if the max flow rate for the device is already there, then move to the next device. You can also refer the patient if needed, according to local protocol. Okay, so let's get back to the algorithm. If the patient did not improve on 5 liters per minute of nasal cannula oxygen, then move on to the next step, which is the simple face mask. The simple face mask does not have a reservoir bag. It can be set at flow rates of between 6 and 10 liters per minute and provide oxygen concentrations of between 44 and 60%. So it provides a maximum FiO2 of 60% at 10 liters per minute. Let's talk about how to actually use the simple face mask. First, you must set up the device for use. Start by selecting the size of the face mask. They usually come in pediatric and adult, but other sizes are possible as well. Select the right size of mask by holding it lightly over the face, ensuring the bridge of the nose is covered and that the bottom of the mask rests below the lower lip but not past the chin. This guide to sizing will work for any type of face mask, from the simple face mask to a Venturi mask to a face mask with a bag, and even for the mask of a BVM. Imagine 2 lines from the bridge of the nose to the bottom of the face, between the lower lip and the end of the chin. The face mask should fit between these 2 lines and not be too big that it covers the eyes and not be too small that it doesn't reach below the lower lip. If the mask you have selected fits these parameters, you have selected the correct size. But don't apply the face mask just yet. Now that you have selected the right size of mask, but before you apply the mask, you need to connect the tube to the oxygen source and turn the flow rate to 6 liters per minute. Once the oxygen is flowing through the mask, then apply it to the patient's face. A face mask without O2 flowing through it can be very suffocating to a patient with respiratory distress. This is why we always dial up the oxygen flow at the source before putting any oxygen delivery device on a patient. Next, place and secure the elastic straps around the head, as shown. Adjust the straps by pulling on their ends to ensure a secure fit with minimum air leaks from the sides. If the mask has a metal strip at the bridge of the nose, mold this with 2 fingers on each side to minimize air leaks. Place a surgical mask loosely over the mask. Do not block the little holes of the mask completely, as this will cause the CO2 the patient is breathing out to become trapped in the mask. Monitor the patient's oxygen saturations and respiratory rate for improvement. Monitor for improvement, just like we did with the nasal cannula. The difference here is because we started at 6 liters per minute and the simple face mask can go up to a flow rate of 10 liters per minute, you can dial up the oxygen flow rate if there's no improvement. If you have reached 10 liters per minute and there is still no improvement, then you need to move on to the next device. Before we go on to the next device, I wanted to clear up something that might confuse you. There are two types of oxygen masks without a bag. The simple face mask, which we have spoken about, and the Venturi mask. You can tell the difference between these two by looking at the place where the tube connects to the mask. In the Venturi mask, there is a colorful bit of plastic with holes in it that connects the mask to the tube. In the simple face mask, there is no colorful bit of plastic and the tube connects directly to the mask. This colorful bit of plastic is called the Venturi piece and lets us give very precise oxygen concentrations or FiO2s to the patients. Venturi masks come in different FiO2s or oxygen concentrations. You get Venturi masks which give oxygen concentrations of 24, 28, 31, 35, 40, and finally 60%. Because of this, only the 60% Venturi mask represents an increase in FiO2 over the nasal cannula that we talked about earlier, which has a max FiO2 of 40%. Therefore, if you are going to use a Venturi mask for escalating oxygen therapy in the COVID patient, and you have already used a nasal cannula at 5 liters per minute with no improvement in the patient, the Venturi mask you will need to use to provide a higher FiO2 would be the 60% Venturi mask. Venturi masks need to be set at a particular flow rate to achieve the FiO2 that it is set at. But don't worry, just look on the colorful bit of plastic and it will be written on it at what flow rate you need to set it at. For the 60% Venturi mask, it is usually set at 15 liters per minute. Now, given all these technicalities and the limited use of the Venturi mask in the general COVID patient, we would suggest that you use the simple face mask over the Venturi mask where possible. If the patient does not show an improvement with the simple face mask set at 10 liters per minute, then the next step is to use a face mask with a bag. Have a look at the summary in the algorithm, enlarged and shown here, of the face mask with a reservoir bag. We will go into details of its use shortly. So if the simple face mask set at 10 liters per minute does not result in a patient improvement, the next device to use is the mask with a reservoir bag, which is also known as the Non-Rebreather Mask. This mask is able to deliver 85 to 95% oxygen concentration or FiO2 when the bag is inflated. We will talk about this shortly. A flow rate of 10 to 15 liters per minute should be set at the oxygen source. As you can see, this mask has a few differences from the simple face mask. The most obvious difference is that it has a clear plastic bag called the reservoir bag at the bottom of it, the red arrow. It also has 3 valves which allow gases to flow in one direction only. 2 of the valves are located on the mask itself and are easily seen on the sides of the mask, the green arrow. The 3rd valve can be seen by turning the mask around and viewing the inside of the mask, the blue arrow. 100% oxygen flows from the oxygen source and through the tube and collects in the reservoir bag. The patient then draws in this oxygen from the reservoir bag through the one-way valve, which only allows oxygen to go from the bag to the mask, but not from the mask back into the bag. After the patient has taken a breath in and then exhales, the gases like carbon dioxide that the patient breathes out is blocked by the one-way valve at the top of the bag, the blue ring, from going back into the bag, so that the oxygen in the bag remains at 100%. The gases that the patient breathes out is instead sent out at the sides of the mask through the valves located there. The valves at the side of the masks also don't allow the patient to breathe in room air from the side valves, and only let the patient breathe out through the side holes on the mask. From this arrangement of the bag and valves, the patient is able to breathe in 85 to 95% pure oxygen. The reason that is not 100% oxygen is that there is always some leakage at the sides of the mask where it sits against the face. However, what this valve system also means is that if the bag is not fully inflated or the oxygen flow rate is low or turned off, the patient won't be able to get much oxygen at all because the bag will not be full. So the golden rule of using the non-rebreather mask is to always make sure that the bag is fully inflated before and during patient use, or the patient could suffocate. Some face masks with a bag have only one or sometimes no side valves on the mask. That is okay too. A mask with only one side valve is called a partial rebreather mask, and a mask with no side valves is called a rebreather mask. The oxygen concentration that the patient breathes from these masks will be a little less than the non-rebreather mask because the patient can take in air from the holes in the sides of the mask, but it will still be higher than 60% oxygen concentration. Okay, so let's talk about applying the non-rebreather mask. First, select the correct size of mask, just like with the simple face mask. The top of the mask should be at the bridge of the nose, and the bottom of the mask should be in between the lower lip and the chin. Then check that the non-rebreather mask is working properly by following these steps. To use the mask with Reservoir Bag, first we must check that both the valve and the bag are functioning correctly. To do this, you first attach the tubing to the oxygen source and set the flow rate at 15 liters per minute. Turn the mask around so that the inside faces you, locate and then block the valve between the mask and the oxygen reservoir bag with your finger and watch the bag inflate. Following this, release the valve and squeeze the bag, ensuring the bag deflates. If the bag inflates when you block the valve and deflates when you squeeze the bag, that means that the face mask with the bag is working well. This should be done for every single face mask with a bag before you treat a patient with it. Now that you know your face mask with a bag is working well and has been checked, you can now get it ready for patient use. Make sure the oxygen flow rate is set at between 10 to 15 liters per minute. It is extremely important to reinflate the reservoir bag by occluding the valve between the bag and the mask. Only once the bag is fully inflated should you then place the mask over the patient's nose and mouth. Place the strap over and around the patient's head and adjust to fit by pulling on the ends of the strap. Observe the bag while the patient is breathing. You will see that the bag deflates when the patient takes a breath in and then reinflates while the patient breathes out. During this process, the bag should never become completely empty at any point. It should only deflate by a third. If the bag is deflating completely, then increase the flow rate to a maximum of 15 liters per minute until the bag remains partially inflated even when the patient takes a breath in. Cover the non-rebreather mask with a surgical mask, taking care that the surgical mask is not too tight. If it is too tight, the valves at the side of the mask could become stuck, and the patient will not be able to breathe out very well. Wait 5 to 10 minutes and recheck the respiratory rate, the oxygen saturations of the patient, and the feeling of shortness of breath. If these are improving, then keep the patient on the current flow rate. If the patient is not improving or getting worse, then increase the flow rate by 1 to 2 liters per minute at the oxygen source to a maximum of 15 liters per minute. If, after increasing the flow rate to 15 liters per minute and reassessing the patient after 10 minutes with no improvement, then it is time to move on to the next and final step, which is the combination of nasal cannula and non-rebreather face mask. The final oxygen delivery devices used in the algorithm is to combine the nasal cannula and the face mask with a bag. Have a look at the summary in the algorithm, enlarged and shown here, of the combination of nasal cannula and face mask with a reservoir bag. We will go into the details of its use shortly. To combine the nasal cannula and the face mask with a bag, first start by going through the steps of applying the nasal cannula. Select the right size nasal cannula. Connect the nasal cannula to another oxygen source. You may need to find another oxygen cylinder or use a different wall oxygen point. Set the flow rate to 5 liters per minute. If you are following the algorithm, the patient will already have had on the face mask with a bag set at 15 liters per minute on a different oxygen source. Remove the face mask with a bag and apply the nasal cannula. Remember to aim the small tubes that go into the nostrils curved downward. Wrap the nasal cannula around the ears and adjust the slider to fit snugly under the chin. Make sure that the patient's nostrils do not turn white or pale, indicating you need to use a smaller nasal cannula. Then reapply the face mask with a bag, making sure the bag is well inflated and the flow rate is 15 liters per minute. Apply a surgical mask over the face mask with a bag, taking care that the surgical mask is not too tight. Observe the reservoir bag, making sure that the bag does not completely empty between breaths. The final step in the algorithm is to think about what to do after using the combination of nasal cannula and the face mask with a bag. Monitor your patient for improvement and reassess the respiratory rate and oxygen saturations at 10 minutes. If there is an improvement, that is good, but you should still inform a senior healthcare worker, as a patient requiring this much oxygen may deteriorate quickly. If there is no improvement, inform a senior healthcare worker immediately or call for help from your referral institution. Depending on local policy, manual ventilations with a bag valve mask may be commenced, or the patient may need to be intubated. In settings where high-flow nasal cannula or CPAP equipment and expertise exist, these may be commenced prior to intubation depending on local protocol. Because manual ventilations, intubation, high-flow nasal cannula, and CPAP may cause the coronavirus to become airborne, make sure that you are wearing full PPE with airborne precautions, including an N95 mask if you undertake these procedures. So we have covered the different devices we use for oxygen delivery and how we work down the algorithm based on the patient's condition. It is important to remember that this is a dynamic process and the patient's condition can change rapidly. If there is a change in the patient's condition or in the oxygen saturation readings, we need a way to assess what has gone wrong. We do this using a troubleshooting checklist. Troubleshooting is a process where we find and correct any faults in a system during its use. Troubleshooting may be necessary during oxygen therapy when a patient isn't responding to therapy in a way you would anticipate. For example, if the patient becomes suddenly worse despite adequate oxygen therapy. Troubleshooting can also be applied after every step in the algorithm, similar to how we would monitor the patient for improvement. If the patient is not improving, you can go through these steps to make sure that the patient's condition has not changed and the equipment is working well. The two things to assess closely are the patient and the equipment. Firstly, as with all patients, you should carry out a simple ABCD assessment to ensure that no significant change in the patient's condition has occurred. The ABCDE assessment is out of the scope of this lecture, but is available in many medical resources if you are unclear of how it is performed, including the WHO's Basic Emergency Care course. This is a free open access course and can be found at the link provided. Once an ABCDE assessment has been complete and any problems identified in the assessment have been addressed, move on to check the equipment. There are two types of equipment failure to check against. The monitoring equipment, such as the oxygen saturation monitor. Here, you should check that the fingernail does not have nail polish, as this will interfere with your reading. Check that the probe is on correctly. Check that the blood pressure cuff is not on the same side as the probe, as when the cuff is inflated, this will cause falsely low SAT readings. Oxygen saturation monitors can be small, battery-operated and portable, but others are larger with wires that must be attached properly and the machine plugged in and powered on. The other type of equipment failure to check against is the oxygen delivery equipment. We will talk about this in greater detail in the next slide, but the categories under which to check this equipment is the oxygen source, the tubing, and the delivery device itself. So let's take a closer look at how to check the oxygen delivery equipment. As mentioned before, this can be checked under the following three categories: the oxygen source, the tubing, and the oxygen delivery device itself. A good way to order this evaluation is to start at the source and follow the equipment to the patient, checking each aspect before moving on to the next. So let's start with the oxygen source. This can be either a wall point or cylinder. Ensure it is oxygen and not another gas. Remember that different countries use different color codes for oxygen cylinders, so check that this is correct in your setting. Ensure that, if using a cylinder, there is sufficient oxygen by checking the pressure gauge, and ensure that the flow control valve is opened to the desired flow rate. If using wall oxygen, check that there is not damage to the connector and that there are no leaks. Move on to the tubing. Follow it from the oxygen source to the patient, looking for any damage, leaks, or kinks. Then check the oxygen delivery device itself, either a mask or mask with a reservoir or nasal cannula. Again, ensure that the connection between the tube and the device is not damaged and there is no leak. Ensure, if using a mask, that there is a good seal around the patient's face, or if using nasal cannula, that the prongs are secured in the nostrils. Finally, check the specific oxygen device features. For example, if using the mask with a reservoir bag, ensure that the bag is full and that the valves are patent. And for any device, check that the correct oxygen flow rate is selected for that particular device. Finally, it is important to check you are confident with your suspected diagnosis. Take a moment to consider the differential diagnosis and any other factors you may have originally missed. If you believe you have exhausted all treatments so far, then it is time to consider more advanced therapy in the form of non-invasive ventilation or intubation, for example. Topics which are covered on other AFM tutorials accessible on the AFM Resources webpage. And that wraps up our tutorial on basic graduated oxygen therapy. Thank you so much for tuning in. I really hope that you enjoyed this tutorial. For more great AFM tutorials, videos, and resources, please go to afm.africa/resources.